So welcome back to the second part of the program. This is our presentations. And also, as you'll see, the front tables all have microphones that have been passed around, or some other tables as well. And they're on off. But once we start the Q&A, will there be some time for people to answer questions, Dr. Vora? Ask questions? Yeah, so please use the microphone because we're recording this. And then you can just turn it to green, which is the on signal. Excuse me. So Dr. Vora, I wanted to just tell you a little, it says right there, who's the chief of psychiatry at Woodhull and a Downstate grad, clinical associate professor and vice chair, NYU Grossman School of Medicine. Welcome, Dr. Vora. Making career choices.
Thank you so much for inviting me. I have to say that I totally didn't expect to be here, but I'm so happy that I'm here because it's so nice to see my past looks still like my present. It's incredible to see some of my teachers who look like they haven't aged a day, which is great. And it's very nice to run into people. I do feel that I don't, listening to the history of Downstate that Dr. Viz presented, it makes me so proud that I was a part of this. And 20 years ago, it doesn't seem like that. It feels like it was just yesterday. And I really am like touched to be here. I don't feel that I am anywhere close to the giants that are in this room and what they do. But I think that this might be a good talk for residents because I think the day and age that we are in now, I think I'm different than a lot of other people who have stayed in the field and steadfast and keep working on some projects and research. I have moved around a lot. And I think I have sort of like gone with the tide and sort of followed what I enjoy doing. And I think I'm sort of, seeing myself as a chief of a department at this age in a very, very difficult system. It kind of feels like it would be nice for more young graduates to see that. So thank you, Scott and Dr. Myers, and for inviting me to do this talk. I graduated in 2008 when Dr. Rao, who was a program director the year before, had just left, and he had gone to be the chair at Nassau University Medical Center. This was in Long Island. It's private. It's the only safety net facility in Nassau, and it's kind of like doesn't have a great reputation. I think it didn't when Dr. Rao was there too, but he kind of left there to be the chair. I think to be close to home, and I think again the public mission I think was something that was always important. One of the things that when Dr. Viz was talking about the G building, I think I agree with you, Dr. Viz, when you say that once you've worked in the G building, you can work anywhere. It doesn't matter where you are, you've got it. So when he told me to come with him, again, as being an IMG, one of the things you want to look for is, which program is going to sponsor your visa, your green card, like those things become important, which is something that Downstate does more than any other program in the city because, first of all, we have stellar quality, but then we are set up with success to find jobs that will also take care of that part of our life, which a lot of other big academic centers don't know how to take care of. So, Dr. Rao was like, I'll sponsor your residency. I know you want to be in administration. I'll get you a good sort of administrative position. So I followed him. And back then, as an IMG, like this was one of the big things, I was trying to debate between a fellowship. I knew I didn't want to go to Child or Jerry. Like I had a lot of options. But I think it became sort of easy to follow my program director, who was an IMG champion. Like there was so much that he was offering, and he assured me growth and advancement. And I trusted him, wanted to be with him, and so I took that job. And of course, like he had promised, I kept growing, really quickly. One of the things that I did do as a part of his, being in GAP, I'm working with Dr. Julie Rance, who was also in GAP then, who had the public psych fellowship, which I was always, I wanted to do it, but I also wanted to sort of make sure that I was able to, get my visa situation taken care of. So he made me attend the fellowship as a full-time attending, which is not something that commonly happens. But that, I think, was a singular experience of my life that sort of changed the trajectory of everything that I could do. Because while I was there in that fellowship, and so for any of you that are interested in public psychiatry, I would put in a plug for that fellowship. It's something that will absolutely change how you think about administrative psychiatry. And I became the medical director of the outpatient program. I became the director and quickly became the vice chair over there within like a few 6, 7 years. But I think one of the things that helped me was my ability to really work in a true public psych program. Everyone that was there was a little bit like Kings County, mission-driven, passionate, wants to be there because they are really want to take care of the patients. And it was a place that was, a little bit of a mess, but to me, that was an opportunity to grow. That was an opportunity to fix things. And it was easy to fix things because no one had done like simple things that we had learned in residency. As residents, as chief residents, we were given the tools to like manage places, manage programs, and I think no one was doing that there. But of course, having Dr. Rao there was super important. Like, I think that was the true reason to try to take that, that risk that I did take at that time. There was a very political place. Ultimately, I think there was a new CEO, and I was kind of like done by that time. And then a new opportunity came along my way, which I thought I kind of needed to challenge myself. Like, I went all the way up to being the vice chair. What next now? I don't have anything else to do here, much more to grow. And this is one of the other things that I recognize about myself over the years, as I look back in retrospect, is that once I'm sort of stable and settled and feel like, oh, I kind of have done this well, I want to move. I don't like to stay in one place. And then Disrupt came along. I don't know how many of you, I think some of the folks who have been around for a little bit might know this, but 2015 to 2020 was a great years for New York State when this new opportunity came along, where the state of New York decided to give like a lot of money to safety net hospitals to create programs that were really supporting primary care and behavioral health. So I started doing this with Nassau, with the Newmark Hospital, but then Northwell Health, which was a partner in our region, was also working on the same projects. And then Northwell ended up recruiting me to basically lead all of their district programs for all 23 of their hospitals. And that, I think, became like a great opportunity for me because population health was just growing. That department was not what it is now. Back in 2015, it's like 10 years ago at this point, it was like in fledgling states. And I had a unique position where I was straddling the departments of psychiatry and behavioral health. And population health. And that was not common for psychiatry to be given a place in pop health because mental health issues were not really seen as something that can be prevented on a mass basis. But Disrupt gave that opportunity. Integrated care, which is now sort of like the buzzword, and every place has integrated programs, back in 2015 existed in Washington. Like, Ames had done a great job, but I don't think that we had a lot of other programs across the country. But this was, I think, one of the most fun and creative jobs I had. And it was like a little bit like being in utopia because it was like, here's all this money. There's millions of dollars. Create new programs. And couldn't be better because when else does psychiatry get money in public psychiatry, right? Like you don't. You can get research dollars, but you don't get money to do public health work. So while I was there, I was able to create like 27, I embedded psychiatrists and social workers in 27 of their practices. I created their first sort of walk-in clinic. So I don't know how many of you know or aware of Northwell Health, which is like Zucker is a big hospital, but they have like their only walk-in program, which is like 7 a.m. to 7 p.m., true walk-in program. I helped them create that. I created that for their children's hospital. And I think I was able to like really create good systems, which helped because it was smart, again, mission-driven people, and a chance to think outside the box. And of course, I live in Long Island, very close to where I was, so it was a great job. But at the same time, I started missing true psychiatry, right? Like I wasn't dealing with my peeps. Like being in Kings County, you want to see your severely mentally ill people. That's what drives you to like, a public psych place. And then I kind of didn't enjoy not having residents, not having the teaching aspect of it. Felt like I didn't have a clinical connection to so many of the patients and staff. And then it felt like, okay, the next step up, I'd be going into corporate healthcare. I wouldn't be a part of psychiatry anymore. So ultimately, I ended up leaving to go to Mount Sinai, which again, I got a huge opportunity. I got recruited. And I kind of ended up getting like a vice chair position, which at that point seemed like a pretty big deal to really create. And the reason I was recruited there was to bring public psychiatry to an academic medical center, which also felt very interesting and felt like a challenge and said, okay, this would be a good way to do it. And I think I really had a good time there because now I'm sitting in the middle of like research and education. And here I am helping them really develop more programs and really learn how to have a functional and quality department. But eventually, I think I ended up sort of getting a little bored there, created new programs, helped a lot of the public psych infusion. Like a lot of the residents from Sinai started going into Columbia Public Psych, and now are working, actually, all of them are now transferring over to H&H, which is great. I feel like it's come back full circle. But I feel like eventually I got to a point after 5 years going through COVID that I kind of felt like, now I'm getting bored again. I think I want something new. I want a challenge. And that brings me back to H&H. And to me, it really felt like coming home. This has really been, I think, the most challenging position that I've taken so far. The department was, and Dr. Ananthamurthy can share, she knows because she was there as a consultant before I was brought in. The program had a lot of issues. It's a very big program for an H&H hospital. It's got like 89 beds, 19, like a massive CPAP, EOB, mobile crisis unit, ACT team. So I think in comparison to King's, I think it's a pretty decent sized program. I think the only thing we don't have is child units, I think, and some of the extended care units. But we have a lot of programs. And when I went there, there was no staff. There was no quality. It was really, really very understaffed, and there was a lot of violence, there were a lot of assaults, staff were leaving left, right, and center. And I think it was really an old way of doing things. Again, one of the things that I've always said is that if you don't have residents, you don't have teaching, you don't have a reason to kind of like elevate yourself and make yourself accountable. So coming in, I think I had my work laid out, which I think I have, but in the last 6 months, I think I have been able to accomplish a lot. Dr. Bauman, who was with Dr. Ananthamurthy a few years ago, she was phenomenal. She's been, helping me a lot to rebuild. But I actually created a CL department. I created a lot of NPs. I filled all the inpatient vacant lines. I don't have locums anymore. I've hired like a great administrative team where actually yesterday we had an assault, but 6 months ago, 3 months ago, I would not have been able to be here today because I would have been managing the place there. But now I have a team that's taking care of things. I've hired 2 vice chairs, and one of them is actually going to help me start a residency program. So I'm actually going to be putting in for that in the next year because I think that was very important to me. But in 6 months, we've hired about 100 people across all lines. And that, like, to me, it's like, how does the department function with that many vacancies? And obviously it was a mess because they didn't have people. And I still have another 40 lines that I'm still actively recruiting for. And I know some of you have, like, some residents have reached out for moonlighting. Again, that's open too. But, just putting in a plug as I go. But I think one of the things I really want to, emphasize is that as you move through your career, I think, yes, research is a fantastic way, and I do believe that that's important. But I think if you are in the public psych space, and that's what you want to do, I think that there's so many opportunities. I'm lucky to be, affiliated with NYU because there's so much of an influx of, advantages of being a part of that. Like we have all their grant rounds, we have their faculty, we have faculty members with them. And I'm creating a perinatal program, I'm creating an IOP. So I have support that is letting me build more things. But I think over the years, I feel what I think is like, don't just follow what everyone else is doing. Know yourself. Really, truly know what you enjoy doing. Because if you enjoy what you're doing, and if the job that you're doing is fun, then I think you will just succeed wherever you go. But I also think mentorship is super important. I feel like I owe a lot to my mentors because every position that I have taken, I have followed somebody that I respected, that I trusted, that I wanted to work with, and that I knew would support me, right? So before at NUMIC, it was Dr. Rao. Then when I went to Northwell, I had Dr. Greenwald. And then when I moved out from Sinai, so I continued to stay in touch with all my mentors who helped me, guide me through my process. So it's important to make sure you have a good mentor. And the last thing I would say is very important to ask for work-life balance. I think when I trained 20 years ago, that was not a thing. And it took me a little bit to understand, but I don't think I could have gotten to where I am. I have a second full-time job. I have 2 kids, and it's a lot to go through all of this and still also manage the rest of your life. But I think it's important to advocate for that. It's important to make sure that you let the people that you're working with know that this is what you want and this is what you can and cannot do. But don't be afraid to make choices. Don't be afraid to switch jobs. Don't be afraid to try out something new because there's just so much available today that I think it's easy to succeed if you really are passionate about what you're doing. So yeah, thank you for inviting me. Like I said, this was just a... Okay.
We have time for one question. And Michael has. Michael, make sure you turn it on. Is it on?
Hi, saw your posting for moonlighting position at Woodhull.
Louder.
I know a lot of us are interested in that position, and I just wondered if you had any advice on how to get moonlighting working in Kings County as well.
In Kings County?
And can you repeat the question of the recording?
I know. The question that was asked was, I'm like trying to get moonlighting started at Woodhull, but how to get it done in Kings County. I would let Dr. Ananthamurthy answer that, but I can tell you from my part, like I said, Woodhull has not had basic systems in place for a long time, and me coming in, I'm bringing in new ideas. And so because I'm bringing in new ideas, I'm getting the support for the budget and for the funding, which that generally ends up being the linchpin, right? Like, but I have the support of NYU, who wants to see me succeed and Woodhull succeed, and I also have, because we had so many vacancies, we had a lot of money. There was nobody using the money that the lines were supposed to have. So I have some leeway, which is why I can do it.
Thank you very much, Dr. Vora. Thank you. We're just trying to continue on the schedule. Maybe you could talk later. Our next speaker is Dr. Mantosh Dewan, and he is the president of SUNY Upstate. He's a psychiatrist. I know him from GAP and many other things. And he is a SUNY Distinguished Service Professor as well as Dr. Viss. President Viss, High Honor and Big Challenges is the title of his talk.
Good morning, and again, I'm going to start with, I'm delighted to be here. Thank you, Dr. Myers, for inviting me. But I'm going to start with conflict of interest statement, as you required. I've known Viss for decades, and I both respect and love him, so everything I say will be biased. But I really am really delighted to be here. So very, very quickly, I know you've heard a lot of this, but I found he's exceptional. We all have one board certification, maybe two, not this guy. I mean, I didn't even bother to count how many he has. It's the same thing with jobs. Come on, Viss, stick with one job. What is this? Give others a chance. But it's so typical of him that in any of the areas that we value, he does just more than everybody. And that is truly exceptional. You have an unbelievable record, and I know all of this will hold him in very good stead when he becomes president or has become president. Just very quickly remind you that the APA is the oldest. It is the largest in the world. And to be picked to be president out of 38,000 people, that's a real honor. I mean, that is special. And as you know, it's highly, highly, highly contested, and it takes years of working through the system to even be eligible, to be known by enough people. So Viss has done all of it and done it with amazing, amazing grace. Want to point out that of all the thousands of psychiatrists in the SUNY system over the years, he's the first to become the APA president. Amazing. That's, again, really remarkable. And then being the first Indian American.
Second.
You're the second.
Yeah, Dilip just gave us the first.
That's correct. I forgot about the lip. So second, I told you my conflict was I'm biased towards him. Okay, I'm insisting you're the first. But honestly, I do want to emphasize that the best part of Viss is not all his credentials and his achievements, but he's a truly humble, sweet, good human being. That is what I value more than anything else. And his sweetness and his humbleness is paired with another quality that I find really interesting, where in a difficult situation where everyone's sitting uncomfortable saying, should I say what should be said? Viss is the guy who's going to say it. And he's very direct. He'll always speak up. And because he had such high respect, I think he gets away with it where we wouldn't. And that's courageous. And I will give you one example from his priorities. I pulled this right off of his website. I have never, ever heard any psychiatrist dare have the courage to say, we are going to fight inadequately qualified people encroaching into psychiatric practice. Wow. Wow, that's your starting point, sir? Them are fighting words. It's obviously important. It's obviously what a lot of people struggle with, and we cover, but he puts that up as his number one priority. His second priority is to augment the psychiatric workforce, and clearly the two are related. Because of the shortage, we have number one. We get that. So I'm going to give you some data about these 2 points, starting with augmenting the psychiatric workforce. So estimates are we need 15,000 more psychiatrists. And everyone said, oh, you're never going to get there, so why don't we do some alternatives? Let's have other people join the core team. I want to point out a couple of things. Every year, every match, which just occurred in March, 3,000 US citizens. These are our kids who either went to US MD, DO schools or went abroad, mostly to the Caribbean. 3,000 of them do not match every year. And you know that if you don't match one year, you apply again, the chances of matching are basically nil. So 3,000 doctors graduate every year and never work as doctors, physicians, ever. That's $1 billion, 12,000 years of training that we throw away every year. I point that out because clearly that has to be part of the solution. So we keep talking about growing more medical schools. That's not the issue. We need more residencies. And for psychiatry, we need more psychiatry residencies. They're generally funded by the federal government, but they capped it at 1996. So whatever your number was, that's what it is. However, as you can see, they've grown. From just 2,000 last 5 years, they've grown by 403. We now have 2,261 this year. And they've grown because the hospitals have learned to support them. Initially, they fought it and said, government should pay for it. But honestly, a resident is paid 50, 60, 70,000 bucks, works not more than 80 hours. So you've got 2 people now for $60,000. And they can be replaced with a nurse practitioner for 130 each. Do the math. So the second paper that we referenced was, we actually studied this in our hospital to convince our chief financial officer that you will save money by hiring more residents. So in 1 year, we added 30 internal medicine residents, and we added more every year. They actually saves money, right? So I think we need, the correct answer right now is we need to go to our hospital and say, can we get more residents? Rajvee was talking about adding a residency. It should be a no-brainer. Residents work really hard. So I think that is one answer for the workforce that the president has to work on. And the other program that we found very successful for the last 15 years, I've been running a program at Upstate where rural hospitals pay all 4 years of training and a little bit for the faculty, in return for which the graduate resident works for 5 years. And you know that the J1 visa, people go to work for 3 years, the day it's over, they leave. Here, we send our resident for each of the 4 years to work at the hospital. And so there's a 9-year history of being on the medical staff of that hospital. Many of them will buy houses, fall in love with the right person, et cetera, et cetera. So you're looking for a permanent solution, and it's gone very well. So I do think that the focus really should be on how do we create more psychiatrists and push for that, because the other war is much more difficult to fight. But let me give you some data on what President Viss has really labeled very accurately, but dangerously, and so courageously. All right. How do we fight the inadequately qualified people encroaching into psychiatric practice? By the way, who are we talking about? I love my team. Everyone is fabulous. Can we get more? We know who we're talking about. So everyone on the psychiatric team is a giant. And so my question was, who is the shortest giant? What does it take? How tall do you have to be called a giant? And so we wrote a paper on that. It's called Pathways to Independent Primary Care, focused on that, but how tall is the shortest giant? And I think that's a very important answer to qualified, inadequately qualified. You get into the wars because if you say anything negative, you're just defending your turf. And so you can't say anything. But I think we need to look at data. And I'm going to show you some data. What are the educational requirements? What are the minimum years of training? And I'm using minimum. And then what, for me, is the most important part of clinical practice? How much clinical training did you get? Because there are all these online courses. Everybody does stuff online. It doesn't teach you anything about patient care. I don't care how many videos you watch. So I'm looking for what is the required minimum clinical experience. And then I've also emphasized supervised, because there's the old joke, practice makes perfect. In the education world, it doesn't. Practice doesn't make you perfect if you learned it incorrectly to begin with, right? And so we need supervision. And I'm going to point out some of the data here. So I'm going to walk you through some dense data, but I think it'd be pretty clear. So to get to be an independent psychiatrist, you need 4 years of bachelor's. You can go to a 3-year medical school, right? We do have 3-year medical schools. So I'm using what's the minimum you need so that we can be fair. A medical school requires 65 weeks of clinical experience, supervised, under LCME. It's a requirement. So it's a minimum of 65. Remember, it's usually 3rd and 4th years, sometimes in the 2nd year as well. So it's much more. It's usually 80, 90, but I'm looking at my minimum. So 65 clinical weeks in your medical school, and then 4 years of residency. I basically took 45 weeks, give you plenty of vacation, and remember, it's 40 hours a week when it's actually not. So again, I'm looking at the very minimum. 245 weeks of clinical supervised experience, 11 years, you become a psychiatrist. Let's look at the others. You can get an RN in 2 years. The minimum required is 15 clinical weeks. Right? Everyone does a bachelor's online. There's actually not a real bachelor's available, partly because RNs are working, but they don't have to be. You could be running through doing the online quickly. So 2 years to a bachelor's, and then a master's to get a nurse practitioner's degree is 2 more years, and the requirement is 12.5 weeks. So you can now become an independent nurse practitioner with 27.5 weeks compared to 245 for an independent psychiatrist, but you can evaluate, diagnose, treat with meds, do psychotherapy. One suggestion, President, that you advocate for psych residency being 6 months. We've just proven that that's all it takes. Yeah. Unless we are taking the most miserably dysfunctional residents and have to train them for 4 years, the correct answer is 6 months is all we need. I will also say one other thing about this. The clinical experience for nurse practitioners and PA is not supervised. Like the LCME, you've got to have a rotation, you've got to have a supervisor, you've got to have a faculty, you've got to have A, B, C, D. Here is, can you find somebody who will let you sit in with you? So it's all observation, and when this nurse practitioner becomes independent, sets up her office July 1st, sees you as the first patient, writes the first prescription in her practice, do you know that that is the first time she or he has ever written a prescription? How many prescriptions have residents written over their 4 years? Nights, evenings, thousands of people and thousands of prescriptions. That is the first time they write a prescription. But according to the license, they can do everything an independent psychiatrist can do. Right? Our other friends do a bachelor's degree, and like medical degrees, we don't have any clinical experience for your bachelor's, and a PA does 2 years, 1 year preclinical, 1 year clinical. And so again, I've taken 45 weeks, as we did for the medical school. So they've got 45 weeks of clinical experience, again, not carefully supervised. And then, of course, because they have more experience and training than the nurse practitioners, we don't let them practice. Now, why's that? Okay. So what we have established is, out of the 3 giants, the shortest giant requires 27.5 weeks of clinical experience, 6 years, and is a nurse practitioner, right? Let's look at the rest in comparison. So what I want to emphasize is part of the craziness comes because it's not a degree you earn and then you get licensed. Licensing is legislated. So you got 300 very bright people in Albany deciding who can practice and who can't. And frankly, they don't have a clue about the differences, right? But they pass laws on what it requires to be licensed. So I'm going to walk you through this. So same thing. Psychiatrists, as we saw, 11 years, 245 weeks, can practice. NPs, 6 years, 27.5 weeks, can practice. Only because group said, we need more people, we need more psychiatrists, nurse practitioners have a strong lobby so they can practice. Okay, fair. And then the PAs, 6 years, more experience, cannot practice. They have just introduced a bill in New York that they will ask for 8,000 weeks of experience for PAs to get licensed. So that's basically 4 years of practice, and then you can get licensed. Makes no sense because they already are taller than the shortest giant, right? Okay. Next week, you have a lot of medical students who will proudly be called doctors. Will walk across the stage, get a diploma. The moment they walk off with that diploma, they're no longer a medical student, and they have less clinical privileges than they did as a medical student. As a medical student, under supervision, you can go examine a patient, write a note, talk to whatever, even stitch. Once you get your diploma, you have no standing. You have a diploma, you're a doctor, you have no license, you cannot touch a person. Okay? So, yep, they can't practice, but they've already spent 7 years and 65 weeks compared to the shortest giant of 27.5 weeks, but cannot practice. It's just somebody made up that rule. What it does take to get a license in New York and in most places is 1 year residency. 1 year in anything, technically. But there isn't a 1 year license residency, if you will. So there are no general practitioners, right? We have general practitioners in every part of the world, except America. Here, everyone's a specialist. But the GP is well known in England, Europe, India, wherever. And so if you did 1 year here, you've now got 8 years, 110 weeks of clinical training, but no one does that. And if you talk with any of your colleagues and say, would you let this 1 year person practice? They'd say, oh God, no. Internal medicine is so complicated, there's no way you can do that with 1 year. So everyone fights it, but quite happy to say, go see my nurse practitioner. Saying like, really? Really? We need to figure out what we're doing. So, yep, you can with 110 weeks and 8 years do the same thing that someone can with 6 years and 27 weeks. But what do we have right now is a primary care. You need to do family medicine, internal medicine, which is 3 years, and now you're up to 200 weeks and 10 years of training. 10 years of training, 200 weeks is equal to 6 years of training, 27.5 weeks in reality. All right. And then psychiatrists, back again, 27.5 weeks to 245 for a psychiatrist, but we do exactly the same thing. And if you add child psych, and I'll give you the 3 plus 3 plus 2 as the minimum, really is 2 more years than that, and a lot more. You're not talking about 290 weeks versus 27. And again, adult psychiatrists will train and say, I'm uncomfortable seeing a kid. NPs will see anybody. How is that? So my recommendation, adult psychiatry, 6 weeks, 6 months. Child, 6 months. You guys are done. How many residents here? How many can we graduate at the end of next year? None of this makes sense because I think we haven't looked at the data and we've been fighting about there's a shortage so anyone can do whatever. We are sort of need-based and legislation-based, but not data-based. All right. I unfortunately did make the mistake of printing this, publishing this, and then have the privilege of signing certificates for PAs and NPs when I strongly disagree with it. But, so I did want to sort of say that is the challenge that President Viss is going to have. He picked them himself. He said this was number 1 and number 2, but this is what you're dealing with. And it's a very hard conversation to have in public. You're the right person, sir. And so for your achievements, for your courage, congratulations, and we wish you the best as you lead us into this battle. But thank you. I'm happy to take hard questions and have Dr. President Vish answer them.
Actually, advocacy is quite important, not just for ourselves, advocacy for our patients. And I think advocacy has to be taught right from in medical school because I also quite interested in public health. As individuals, we treat a small number of people, but we can have an enormous impact from a public health perspective. And also, many we cannot provide many kinds of treatment because the policy doesn't support it, insurance doesn't support it. So it's extremely important to learn the science as well as learn how to advocate for effective policy changes which will be helpful to our patients. So I thank Dr. Dewan because he's not coming from the APA because his university's medical school's commencement conflicted with the APA meeting. So just to come here, he took a plane from Syracuse yesterday and he's going back. So I really appreciate this effort.
No, thank you. Delighted to do that.
Thank you.
Thank you.
Thank you both. Thank you, Dr. Dewan. Our next speaker is Dr. Eric Hollander, and he's going to talk to us about next generation treatments for OCD and autism spectrum disorders. He's professor of psychiatry at the Albert Einstein College of Medicine. He's the director of the Autism and OCD Spectrum Program and Psychiatric Research Institute of Montefiore, Einstein, and editor-in-chief, Journal of Psychiatric Research. Eric, welcome.
Downstate graduate.
Yeah, and a Downstate graduate.
That's right. Okay, well, thank you, Dr. Myers, for that nice introduction and for inviting me. Congratulations, President Viss. Very excited about your year and your initiatives and looking forward to collaborating with you. And it's a great pleasure to be back at Downstate. I graduated here in 1982, so it's been 42 years. I think the place looks great. It's great to be back in the neighborhood, and thanks for having me. Now, one of the people who had an important impact on my career was Donald Klein. He was also a Downstate graduate, and I did a fellowship with him at Columbia in anxiety disorders and the therapeutics division. And he was someone who was very interested in clinical phenomena and developing new treatments. And, you know, I've taken that to heart, and I've focused on certain clinical phenomena that cut across different conditions. I've been interested in trying to understand the basic mechanisms that drive those clinical phenomena and then developing new treatments as well. I guess I would acknowledge funding for some of what I'm going to be talking about from Department of Defense and the Orphan Products Division of the Food and Drug Administration, Foundation for Prader-Willi Research, Roche, Jazz, and Brainsway. So one thing that I've been very interested in is the idea of inflexible thinking, or cognitive inflexibility. And that's a symptom domain that really does cut across different conditions. So it's a hallmark of OCD, clearly present in autism spectrum disorders. It's the rigidity and inflexible thinking that really is causes the biggest impairment in terms of level of functioning over time. But it plays an important role in other conditions like problematic use of the internet, body dysmorphic disorder, eating disorders, obsessive compulsive personality disorder. The cognitive flexibility is rigidity. It's black and white thinking, all or nothing thinking. It's difficulty switching sets, letting go of certain thoughts and refocusing on others. It's difficulty transitioning from one thought to another, focus on one's own thoughts to the exclusion of others. It interferes with problem solving. It interferes with the ability to adapt to a changing environment. So that was a big issue in COVID, where people with cognitive inflexibility had a hard time both in terms of the lockdown and then emerging from the lockdown. And then it's hard to treat, and it has a big public health impact. So there are first-line treatments for obsessive compulsive disorder. We know cognitive behavior therapy and serotonin reuptake inhibitors, or the combination, is really the first-line treatment of choice. The problem is that about half of patients really don't have a good response to that, which means that we're dealing with lots of patients who are inadequately treated or resistant or treatment refractory. One approach that we've just recently looked at is intranasal esketamine. And this is now approved for resistant depression, but we see a lot of patients who have resistant depression with comorbid OCD. So this is clinically available now. It's just a racemic variant, the S or the enantiomer that rotates to the left of ketamine. And it blocks these NMDA receptors. It activates the AMPA receptors. It has effects on this mTOR pathway. It affects synaptic plasticity, and it's supposed to have a rapid and sustained antidepressant effect, although sometimes it takes a while, and often the effects wear off, and you need maintenance treatment. So the idea is that you sort of induce the effect, you consolidate it, and then you maintain it over time. So we just looked at 23 patients who all had treatment-resistant depression, but had comorbid OCD that wasn't adequately treated with SRIs and cognitive behavior therapy. And these people were 37 years old. They had been receiving about 24 treatments, and most of them got up to the high dose, the 84 milligrams. Interestingly, about 60% of these patients were rated as being treatment responders for the resistant OCD symptoms. About 40% were non-responders. And then we see that many of these were very much improved or much improved. Some were only minimally improved or unchanged. And here you see sort of their initial baseline and endpoint ratings. So not everybody responds, but about 6 out of 10 have a clinical response who hadn't responded to the standard treatments. And here you see people with a range of different symptoms, whether they're religious obsessions, problems in terms of being able to focus, brain fog, terrible hair pulling problems, all kinds of hypochondriacal and doubting obsessions, gambling disorder and superstitious thoughts, who really had a big response and hadn't responded to the standard treatments. Another newer treatment that's out now for resistant OCD, but may actually be more effective earlier on in the sequence, is transcranial magnetic stimulation. So these TMS devices are widely available. You have the typical TMS, and then you have deep TMS as well, which has slightly broader and deeper stimulation. And using this particular deep TMS device targeting the anterior cingulate cortex, which is an important area where volumetric studies suggest alteration in the anterior cingulate in patients in OCD, that was our target. And here, getting 5 days a week treatment over a 6-week time period, we got an improvement in terms of the obsessions and the compulsions. We compared it to a sham treatment, so there was an adequate control. And maybe about half of patients over a period of time seem to get some benefit. Now, one of the issues here in terms of thinking about treatment guidelines is that the later this treatment is utilized, so the more refractory patient, the less they're responsive. The more that you can incorporate this earlier on in terms of sequencing, the more likely you are to get an effect. Now, we see some really refractory OCD patients. So these patients are pretty disabled. They're often completely non-functional. And at Montefiore Einstein, we have a good neurosurgeon, Ahmad Eskander. So we have a protocol here which involves a cingulotomy plus a subcaudate tractotomy. So this is called thermocoagulation. So we put a fine electrode first into the anterior cingulate cortex and just heat the tip of the electrode. There are other approaches that use sort of focused radiation treatment or new forms of ultrasound to lesion these particular regions. There are 4 sort of standard approaches. We use this combination treatment in the refractory patients of the cingulotomy plus the subcaudate tractotomy together, and that's called a limbic leucotomy. So data with this kind of procedure suggests a relatively large effect size, even in this highly refractory population. And the effects seem to be pretty durable. The biggest fear, I guess, in terms of surgical procedures is that you could hit a blood vessel and get a bleed. That's a relatively rare occurrence. So here you can target, again, the anterior cingulate cortex with these sort of fine electrodes and just heat up the tip, get a small lesion there. And then often we'll do one procedure, which is the cingulotomy, see how people do over a period of time. If they haven't gotten a full response, then we had the second procedure, this subcaudate tractotomy. Now, I started off in obsessive compulsive disorder, but then we had the opportunity to do research in autism, and we saw that many of the symptoms that you see in OCD also present in patients with autism spectrum disorder. In fact, it's one of the two core symptom domains. So everybody with autism has repetitive thoughts and behaviors, some like typical OCD, but some have features that are different. We did the same kind of studies where we just borrowed a treatment for OCD and applied it to autism for people who had lots of obsessive compulsive symptoms, and found that some patients had a good response to the standard serotonin reuptake inhibitors. But we also found that overall, autism patients are a little bit more sensitive to these serotonin reuptake inhibitors and are more likely to get activated. So we have to start at low doses and go up slowly. Now, one recent interest in this field is that there are a lot of patients out there who have autism and terrible disruptive behaviors. So they have severe aggression towards other people. They can have severe self-injury as well. They can have bad temper tantrums as well. These individuals often end up in the emergency rooms. And I understand at Kings County, you have a program for people who have autism spectrum disorders and a lot of disruptive behavior. So this was a family-led initiative where many of the families, in response to these kids having terrible outbursts, decided that they would medicate their children using cannabis. And there is a whole changing landscape with regards to cannabis and cannabinoids in the US and in different states. So the idea here was to use it on an interim basis to treat these terrible disruptive episodes. Now, we have an endogenous cannabinoid system that includes things like anandamide, or the bliss chemical. And this binds to these cannabinoid 1 receptors in the brain and the central nervous system, and the cannabinoid 2 receptor in the immune system. We also have plant-based cannabinoids like THC and also CBD and CBDV that have different types of effects. So there are lots of things in the environment that will affect our endocannabinoid system. So stress has a big effect, food, obesity, exercise, inflammation, tissue injury all affect circulating endocannabinoids. And then these have all kinds of effects in mood and anxiety, in suppressing or activating food-seeking behaviors and breaking down fats and satiety. And these things have big effects on T cells and affect cytokines. THC, which is the compound that gets you high, binds to the cannabinoid 1 receptor, and this works through second messenger systems like this mTOR pathway. CBDV, which is another compound that can be extracted from the plant, doesn't bind to the CB1 or CB2 receptors. It binds to this GPR55 receptor. The GPR55 receptor is interesting because it modulates glutamate and GABA effects and excitation and inhibition balance. And the CBD actually binds to a lipid, this lysophosphatidyl'inositol, and pulls it off that receptor. And what's interesting is by reestablishing this excitation-inhibition balance, it has potent anticonvulsant effects. So CBD or CBDV is used to treat refractory epilepsy. Now, one of the ways to try to develop new drugs in these areas is to try to focus on rarer but more homogeneous disorders that have just a single gene that seems to be playing a role. The biggest problem in developing new treatments is, we have complex disorders and multiple different genes, and that causes a lot of noise, and it interferes with getting a good signal between a drug and a placebo. One alternative is to focus on these rare disorders where there's a single gene involved, like Prader-Willi syndrome. So this is sort of a monogenetic form of compulsive disorders, where these individuals have severe compulsive eating, terrible rigidity, If there's a deviation from their routine or their schedule or their eating time, they have a lot of discomfort, and then they explode. They have all kinds of skin picking problems as well. And we developed a scale to look at this rigidity, behavioral rigidity, which is how much discomfort people have if there's a change in the environment or a change in their schedule. How much cognitive rigidity they have, how flexible is their thinking, and how much do they protest in response to deviation. And when we give CBDV to these young people who have Prader-Willi syndrome, we find overall a reduction in the rigidity scale scores, a reduction in their protest, and a decrease in their overall measures of cognitive and behavioral and protest rigidity. So it may be that one compound that affects this cannabinoid system and sort of reestablishes this excitation-inhibition balance may have some positive effects on this particular domain. Another compound that has been of interest in autism is oxytocin, which is a peptide in the hypothalamus, which is involved in milk letdown and uterine contractions, but it's also involved in the social brain circuitry in recognition of other people and developing social memories and developing trust. And there's this communication between the peripheral and the central oxytocin system. And the vasopressin system and these vasopressin 1A receptors seem to have reciprocal effects from the oxytocin system. And also, it plays an important role in wound healing and inflammation and obesity. So if you knock out the gene for oxytocin, then animals may not recognize other animals. And those species that are very, very social have lots of vasopressin and lots of oxytocin receptors in their social brain circuitry. And when you show people threatening or angry faces, their fear center or their amygdala lights up. If you administer oxytocin, it shuts down this amygdala firing in response to social threat. So we were working with Roche to develop balovaptan, which is a vasopressin 1A antagonist, and here focusing mostly on the social communication domain in autism. And the early studies in adults looked pretty good, actually. There was a little bit of a dose-response relationship, sort of a moderate effect size. People got very excited. FDA gave this a breakthrough designation. But unfortunately, when we repeated this in children, we really didn't see the same effects. So it turned out that this vasopressin 1A antagonist was no better than placebo, that having higher blood levels didn't make any difference. And also when we looked across the board at things like irritability or stereotypic behaviors or inappropriate speech, it really didn't seem to be helpful. So there's a need to develop new treatments in this area. There aren't great treatments available for rigidity across a range of different conditions. One of the ideas is to target the circuits that are involved to improve things like this excitation, inhibition, and balance, to utilize drugs that have immune inflammatory properties. Another approach is to enhance the production of white matter or myelin with oligodendrocytes. And some of the ways to try to do this is either to pick rare disorders that have just single genes as a cause, to understand, what are the sources of placebo response, and placebo response is what kills drug development, and then to develop better biomarkers, because a lot of the clinical measures that we use are not sensitive and can be subject to all kinds of different bias. And then in these conditions, we have multiple different symptom domains, core and associated symptom domains. To get the biggest impact, you may need to treat different symptom domains. We have to combine psychosocial treatments with our new medicine approaches. I think most of these individuals really benefit from having structure and routine in their lives. We have to find better ways to address inflexible thinking. And then these conditions come with a range of other psychiatric and medical comorbidity. We should be sensitive to that. And then finally, the idea that people present with very different concerns and different symptoms at different stages in their development. And finally, what I would say is most psychiatrists really aren't trained to identify developmental disorders. Most people think that for these developmental disorders, it's behavioral pediatricians and child neurologists who deal with it. But the kids grow up to be adults. It's the mental health comorbidity that really drives all of the negative outcomes for these individuals. And it's really adult psychiatrists who have to manage all of the behavioral and emotional issues in these patients. Okay, well, thanks very much.
We have a few minutes for questions. Dr. Vess.
Thank you, Dr. Hollander, for really this cutting-edge research presentation. I noticed that in the slide, it showed that cannabis increases mTOR, and as we know, there's a lot of interest in mTOR in terms of longevity. Can you comment about that?
Well, a number of these newer kind of treatments do work through this mTOR pathway, which is an important second messenger. So ketamine affects the mTOR pathway, the cannabinoids work through the mTOR pathway. And it is true, like longevity treatments like rapamycin and things like that. So, one idea is this whole biohacking idea. All these people in Silicon Valley who want to live forever and are studying different approaches. And that is one pathway that people are targeting to increase longevity, yeah.
Yeah, of course, with that, there are a lot of other things, adverse effects, which can work in the opposite direction, but people are biohacking.
Right, and they're using like rapamycin as an example, tiny intermittent doses to enhance longevity. And some of the most interesting work is being done in animals, actually, because people really want their dogs to live for longer periods of time.
Yeah, you mentioned ketamine briefly, but have you seen anything with dextromethorphan being effective in these patients as a more stable?
Right, the question is dextromethorphan helpful? And the answer is yeah. So a lot of the glutamatergic drugs are also being studied. I didn't even talk about that, but it's true. I've actually found in this population that the dextromethorphan quinidine, the new Dexa, is really pretty helpful, both in terms of increasing flexibility, reducing anxiety, and then decreasing the protest or explosive behavior. With the quinidine, you need to watch out a little bit for drug-drug interactions or QT interval, and then it's also packaged with low-dose bupropion or Wellbutrin, the idea being blocking the peripheral breakdown, enhancing higher brain levels of the dextromethorphan, which also affects NMDA and things like sigma-1.
Thank you very much, Dr. Hollander. Our next speaker is Dr. Schuyler, who's a professor of psychiatry at SUNY Downstate, and she's going to speak to us with a very, very interesting topic, which I thought, clinical psychopharmacology at Downstate research, teaching, and practice. Dr. Schuyler?
Thanks so much. Thank you. And I want to start, first of all, by thanking Dr. Viswanathan, to us, for inviting me to talk here today. When I looked at my, I guess it's not my calendar, but I think it's my CV, it turns out that I've actually been at SUNY Downstate for 20 years, albeit part-time, and it's been a very, very rewarding time. And first to this, your question to Dr. Hollander was exactly what I've always admired about you, which is the incredible breadth of interest and knowledge that you have in the field, so that no matter what someone is talking about, you're always in the position of being able to ask a good, probing question. Fortunately, this time you got a good response, sometimes not so good. So, now my disclaimers. First disclaimer, this is not my topic. I thought it was going to be what I would talk about, and then I realized, first of all, that there's only 20 minutes, and what I would do instead is something that I always like to do, which is exemplars of what the topic might be. So, my disclaimers, and what is the case for me is that as someone interested in working in psychopharmacology over the decades, clinical psychopharmacology specifically, I've had the opportunity to work with a number of pharmaceutical companies over the years, and it turns out it's been very, very rewarding experience in teaching me a lot about what I do, and also in alerting me to where the world is going as opposed to where the world has been in the arena of psychopharm. So here's what's really going to happen. I'm going to narrow the focus, and what I'm going to try to do in terms of research is give you two examples of research that's been conducted here at Downstate in close collaboration with Kings County over the decades. And from this, you've already heard the names mentioned, David Engelhardt and Peter Wyden, and I'm going to dive a bit deeper into both of those. And partly, it's going to be through a very particular lens, which is my personal experience with both of those people and the research that was conducted. And then finally, I'll broaden out a bit. Dr. McAfee provided me with information about clinical psychopharm training for our residents in the current PGY. And what I've done with that, and with deep apologies to Dr. McAfee, is to take a dive into it in terms of how I see the clinical psychopharmacology training program here from my perspective as somebody who's particularly interested in the area. And with that. So first, David Engelhardt. And what I'm going to be talking about particularly is one very large study that he conducted at the Kings County Hospital Center in the late 1950s and early 1960s. Now, for most of you, I got to take you back in time and permit me a bit of time travel here. Imagine a time when the very first psychotropic medications were just becoming available broadly in the United States, and where patients were generally hospitalized for long, long periods of time that we cannot even envision for patients today, and had to prove themselves able to be discharged rather than our current model, which is you're discharged, please convince me that you shouldn't have been. Mostly you'll do that by needing to come back again within 30 days. At any rate, first of all, the Psychopharmacology Research Clinic was established by Dr. Engelhardt in order to address issues of use of psychotropic drugs, particularly with schizophrenia. And that, of course, is how I came to know Dr. Engelhardt at a time when I was beginning my work in the field. I was at the National Institute of Mental Health. I was very young, I was very naive, I was very ignorant, and David Engelhardt was one of the people who was welcoming to the field to a novice researcher who was not a clinician, but who was interested in learning and interested in doing. And he was absolutely marvelous as someone who would reach out to bring in somebody who was standing in the back of the room, uncertain of where to go. And I also had the experience of doing the first Grand Rounds presentation that I ever did in my life was here at SUNY Downstate, again, invited by Dr. Engelhardt. And I believe I was talking about the initial multi-center collaborative studies that Jonathan Cole at the NIMH had led, looking at the first study's title was 3 phenothiazines and a placebo in the treatment of schizophrenia. So this was a very long time ago, and the only thing I remember about the presentation that I can recall today is that I was used to talking about the drugs with their generic names, and Dr. Engelhardt asked me to please use the trade names because that was what the clinicians and residents were more familiar with. At any rate, this particular study that Dr. Engelhardt was reporting is from a wide range of studies that he did starting in the late 1950s and going well into the 70s. But this one was particularly notable because it was conducted at the county, and it included, and try this number for a minute, 541 outpatient schizophrenia patients. And what was interesting about it is that he described the patients as being representative of the population in Brooklyn and the population that was served here in the community at the time. And that population was 70% white. Today we would probably say 27 of European origin. But this is what was written in the paper that Dr. Engelhardt and Rosen wrote in 1976. And the mean age was 30. They were about 50% male, 50% married, and they're described as being lower social class as measured by the Hollingshead-Redlich Social Class Index. And here's the summary statement from the article. Phenothiazine treatment, and they're not specifying which phenothiazine. One of the things that we had learned was in other studies, it was very difficult to discriminate among the phenothiazine drugs. These would include things like chlorpromazine being the sort of most characteristic of them, was effective in reducing the incidence of hospitalization as well as delaying its occurrence among low competence, hospital-prone patients. But if you get the other group, high competence, non-prone patients, hospitalization rate was not significantly different from the low rate 7.7% of those treated with placebo. Now that's in many ways, a groundbreaking study if you go back to it. We still see that same kind of heterogeneity in patient populations with schizophrenia, regardless of the fact that our drug treatments and other treatments have come to vary so much. And now here's something that's characteristic of Downstate going all the way back and up until the present day. The title of the paper that Engelhardt and Rosen wrote was called The Effect of Psychotropic Medications on Social Rehabilitation in Patients with Schizophrenia. So what they were looking at here was not only their own study, this was a fairly comprehensive review as of the early 70s of what we knew about things that you might do in the way of what they called social rehabilitation for community-dwelling patients with schizophrenia. So that's one example. And now let me move forward. And so now I'm in the 2000s. And This was right after I came to Downstate in 2023. And Peter Wyden, whose picture was already shown by Dr. Viss, faculty, Paige Burkholder, who at that time was the director of psychiatry treatment at the county, and housed in Building G, which has already been referenced. And to the best of my knowledge, I think it's been torn down, and I think that was a really good idea. Because by the time I was working there, one of the things I would have advised when I first got there was, better don't use the elevator. So that kind of tells you something about the state of a building. When you're dubious, and the better don't use the elevator was not on the basis of general physical health. In other words, that it was good for me to climb the stairs. It was on the basis of the fact that there were risks to using the elevator. At any rate, we also had a schizophrenia research program at the county. And this was broader than the study that I'm going to describe, which was a very small study, which was a 2-year open-label randomized controlled trial comparing long-acting injectable medication for schizophrenia. And this was looking at the very first long-acting injectable of the second-generation drugs, risperidone, compared to oral medication. What was distinctive about this, and which is, again, I think the kind of thing that reflects downstate culture, was that the randomization to treatment was not randomization to the drug condition, but it was randomization to being offered the long-acting injectable versus staying on the current medication. And what that meant was that the patients had an option to refuse. To our enormous relief, 76% of the patients who were randomized to receive psychoeducation about medication, which involved family psychoeducation as well, agreed to the long-acting injection. Of course, the patients who were randomized to the oral condition did not have that opportunity. What we were able, and now you see again, the population reflects the community that we here serve. So we distinguished between African American and Afro-Caribbean origin, because those are the populations that we see so prominently here in our area today. Essentially, when you add 32 and 62 together, if I'm not missing on my arithmetic, you're something up over 90% with some African heritage. Again, most of these were single. These were very young, 23 years old on average, and the reason was that we wanted people with very limited exposure to antipsychotics. The goal here was to see whether long-acting injectables could play a role early in treatment before patients had proven themselves irreconcilably non-adherent to medication, which is where many patients receive those treatments today. At 12 weeks, we found that the patients who accepted LAI treatment were more likely to be in treatment. By 2 years, there was no difference in outcome between the two randomized groups. But we noticed, partly because it was a tiny, tiny cohort of patients, we noticed that the only people who were still in LAI treatment in the second year were those who were taking LAI injections, regardless of which group they'd initially been assigned to. So, courtesy of Dr. McAfee, my take on clinical psychopharm training here, and I'm happy to take corrections at any point. First of all, it's a team program, and the goal is obviously to treat the whole patient. The goal is not training psychiatrists to become prescribers. And that is, I agree, I believe, a challenge, because in many contexts, that's basically all a clinician working as a treating psychiatrist is going to have the opportunity or time to do in a 14 to 15-minute timed visit. In the PGY 1 year, as I read it, the focus is on the things that happen, the immediate things that occur, and that require quick response and short-term treatment. In other words, what you see in inpatient units and what you see in the ER, and addiction withdrawal, which is very much the same thing. You really got to act on it right now. In PGY2, it's expanded to look at a range of environments in which patients find themselves. And so what Dr. McAfee provided me with was, there's a subunit on pediatric treatment, and embedded in that is psychopharmacology, similarly for geriatric. And that's the model that's followed throughout, so that you're starting to be able to focus on the larger picture. In the PGY 3 year, what you're looking at is outpatient, which is long-term treatment, which now starts to expose you to treatment refractory patients, because these are the people who, some people are just continuing treatment, and these are the people who may be developing where we can now more readily identify refractory condition. And here we see the first very specific medication focus, with the focus on the S-ketamine clinic, which I know you've already heard about. And then finally, in the PGY 4 year, it's advanced psychopharm, and a number of specific diagnoses that may not have been addressed previously, so that it's refining prescribing skills in the context of complex diagnoses. And I will stop there, happily taking correction. So my concluding thoughts. I was so glad to hear the presentation about psychiatry today in the county, because both of the examples that I've provided represent sharp demonstrations, good demonstrations of the collaboration between the two sides of the street, which some of us occasionally cross without waiting for the light. The populations that are being served have changed markedly, as has changed the facility at the county as well. It's now brand new, spanking, shiny, shiny, bright, as opposed to the G building that I remember so well. And the training in psychopharmacologic treatment is extensive, and again, firmly embedded in the model that you heard Dr. McAfee describe so clearly, that addresses the whole patient and goes very well beyond learning how to prescribe medications. What's the right dosage for who? And finally, it's my extraordinarily good fortune to know the people who embodied this kind of integration of psychopharmacologic treatment in a richer environment. And I mentioned this only briefly, and I just want to reaffirm that. Social rehabilitation, as it was defined in the 60s and 70s, family psychoeducation, as Dr. Wyden and I approached it in the early 2000s. And we see these things continuing to expand. So it's a pleasure to be here, and I hope you appreciate the fact that I didn't tell you everything about clinical psychopharmacology at Downstate and the county.
Thank you, Dr. Schooler, for that trip down memory lane. Unfortunately, because of the time, I'm going to have to ask you to hold any questions you might have for Dr. Schooler to the lunch, because our final speaker, Dr. Mokonogho, has been waiting so patiently for her turn at the podium. I'd like to introduce Dr. Josephine Mokonogho, who is a Downstate graduate And she comes to us from Christiana Care, where she works, and she is also the director of faculty there. She's going to speak about nonsteroidal agents and the management of postpartum depression. It's so nice to see you.
Good afternoon, everyone. Thank you so much for inviting me to speak. I apologize. I am a little verklempt, to use a word that I learned here. Coming back home, seeing my teachers, I discovered my love for CL here, which is what I do for a living. I discovered my love for psychotherapy here, and it will probably be surprising to some people to know that I am one of the advocates for residents using their psychotherapy skills all the time on the CL service. So a little bit about my trajectory. So for the residents, I left here in 2010. I did fellowship in consultation liaison psychiatry and psycho-oncology at Memorial Sloan, after which I went to Crozier-Chester Medical Center in Pennsylvania, where I worked as a psycho-oncologist, doing transplant evaluations, and also as a general CL psychiatrist. I got married. My husband did not like Pennsylvania, so we moved to North Carolina. And I did the same work for a little bit, and then I took a big detour into residency education when I was offered the position of the Associate Residence Director. I immediately emailed Dr. Berkowitz and asked her what she thought, and she said, "Josephine, go for it. I think you would be good." I did that for about a year and a half, and then I became the Residency Training Director, which I did for about 3 years. And that gave me a whole new appreciation for how fiercely Dr. Berkowitz and Dr. Myers and Dr. Goldfinger and all our educators protected us and fought for us as residents, because it is not an easy job. I left that, and then I went to Christiana Care, where I am the Director of Faculty Development. So what that means is that I do a lot of education. I run the grand rounds, and thank you to Dr. Vis for accepting our invitation to come and do grand rounds in December. I also do a lot of teaching for I teach psychiatry to non-psychiatrists, sort of like building your psychiatry toolbox, and that is one of my passions. I'm not a researcher. Nothing I will present here is original research done by me. I identify very strongly as a clinician educator. I see patients and I teach, and that's what I do. So today we'll be talking about neurosteroidal agents in management of postpartum depression. I do have some disclosures and possibly a conflict. So sometime last year, I had a brief consulting relationship with Sage Therapeutics and Biogen, who do make the medications that I will be talking about today. My relationship with them had nothing to do with these medications and started out after I'd already done this work. But it is important to know that they make the company that talks about the medications. So today we will basically be briefly talking about why these medications exist and what they're used for, and possibly future directions and what we've done at Christiana Care. So this is an old diagram. It's been around since the 80s. But this diagram, you can show that all admissions, again, all admissions including for whatever diagnosis, 2 years before pregnancy up until 2 years after pregnancy, there is a definite spike right after people have babies. And for about 20 years, there's been research in why. Medications, regardless of what we do, regardless of how we treat, something is definitely going on when people have babies that causes women to decompensate. A little bit of an overview on postpartum disorders, mood disorders. We have postpartum blues, which is very common. About 85% of people who present with mood disorders, that's what they have. It's short-lived, baby blues, resolves in a few days, possibly 2 weeks. A few of them do progress to diagnosis of postpartum depression. Postpartum depression does happen. About 20% of our patients, 10 to 20% of our patients with postpartum mood disorders have postpartum depression, usually meet criteria for a major depressive episode, often with obsessional thinking and a lot of anxiety symptoms. Postpartum psychosis, sometimes we think about that as the big bad, and it's very rare, but very serious enough that we talk to all our patients about it. and they very often need psychiatric hospitalization and multiple medications for treatment. We fear not just suicide, but infanticide as well. I tell residents, this is the kind of case that gets you on the news. And the way I see every patient on the postpartum unit and the way I document is if something happens and they read my note, I want them to know what I thought about and what I was thinking about and why I made the decisions that I made. So postpartum depression typically would start 1 month postpartum. However, clinically, it can be up to 1 year. And when you think about postpartum depression, well, what is that really? Is it a woman who struggles with major depression and happens to be depressed in the postpartum period? Sometimes that can be called postpartum depression. Or is it something else? Is it something different? Often, it's thought of as a different concept and a different disease. And even patients who have a history of major depressive disorder, they often say, I've been depressed before, but this is different. So there's something different about it. Increased risk for postpartum depression, again, people who have history of depressive disorders in the past, people who have history of postpartum depressive disorders, and also people who have a family history of disorders around times of hormonal change. That's also a significant factor. Poor support system, and of course, depression during pregnancy. So a little note about depression during pregnancy. There does not appear to be a biological risk of increased symptoms of depression during pregnancy. Postpartum has something. Now, that being said, pregnancy itself can be a stressful state, depending on whether or not the pregnancy is planned, whether there's a support system or not, or any complications, whether medical, financial, social, any other complications that can happen that can predispose to depression. But biologically, pregnancy on its own typically doesn't confer additional risk, postpartum does. So when we think about what we call the classical postpartum depression, and we try to differentiate it from non-postpartum depression, some things stand out. Number one, there seems to be a lot of anxiety, a lot of ruminations, a lot of obsessional thinking. And often, if in a non-postpartum patient, they would actually meet criteria for both major depressive episode and probably generalized anxiety at that time, because it seems to have a very different sort of quality, a more anxious quality to it. The recurrence risk is also different. It tends to cluster in families outside major depression. It tends to cluster in individual patients who may not have depressive episodes outside the perinatal period. And as I mentioned before, these patients often have history of depressive symptoms in other times of hormonal transitions, PMDD, and even when they use oral contraceptives. So the exact pathogenesis, what causes this new depressive state? We don't know 100%. We have lots of theories. And it is a major focus. As I said, we've been thinking about this for 20 years. And it definitely, as all our disorders are, an interplay of both genetic, biological, and environmental factors. Two theories that I will be focusing on today are the GABAergic theory and the neurosteroids theory, because that's what led to the medications that we will be talking about. So the GABAergic theory. So we think that GABA, we know that GABA is the calming hormone or the calming neurotransmitter of the brain, and it helps with maturation of the hippocampus and other neurons. It also helps with cognition and memory deficits. Some GABAergic agents have shown in some animal models to reverse depressive symptoms. And also GABA, we know that it helps stress, and we also know that it helps with cognition, which is impacted in depressive symptoms. So for the neurosteroids, allopregnanolone is basically an analog of progesterone. And it's important, it's a very important positive allosteric modulator of the GABA-A receptor. We know that decreased levels of GABA are implicated in increased depressive scores in women who are postpartum, and decreased levels of allopregnanolone also are implicated in increased risk of depression. And allopregnanolone is actually inversely correlated with risk of postpartum symptoms. So therefore, the thought was, not my thought, but the researchers, well, let's see what we can do with allopregnanolone as an agent that maybe we can modify in postpartum depression. So that gave birth to brexanolone, which is the first FDA-approved medication for treatment of postpartum depression. We typically use SSRIs or typical antidepressants, and we know all about them. So what is brexanolone? It is an allopregnanolone analog, which again, positive allosteric modulation of the GABA-A receptor. What else does it do? Well, there's evidence to suggest that it also decreases some inflammatory cytokines, IL-6, interleukin-1 beta, and TNF-alpha, and those are thought to be increased in postpartum depression, and those are significant focuses for ongoing research. So it's very expensive medication, and there are a lot of barriers to treatment because it's restricted and can only be used under a REMS program. It's a 60-hour continuous infusion. However, the results are pretty quick. At Christiana Care, we admit patients typically on a Monday, and by Wednesday, they're feeling better. We do pre and post PHQ-9s, again, not just for insurance, but also for tracking. And we decided to use the PHQ-9s instead of the Edinburgh scales or the other scale because the PHQ-9 was embedded in our system. That's what we did. But when we did the PHQ-9 on Monday, before the infusion, and on Thursday, there were significant differences. Most of our patients presented with moderate severe range, and by the time they leave, they're in the mild to moderate range. Now, one would say, well, if you put any mom who has been with a baby in the hospital for 3-4 days, and all she's basically doing is sleeping and being cared for, of course her PHQ-9 score would go down, and that is correct. However, the results were sustained. In the studies, they were sustained up until 30 days. Some newer studies are showing even longer. In our practice, these patients are doing pretty well. We have been able to decrease medication burdens for a lot of patients, and we've been able to discharge a lot of them back. A lot of them aren't even on medications anymore. So again, the short answer, how does it work? Basically, when you think about pregnancy and late pregnancy, you have estrogen and progesterone rising to support the pregnancy. And once women has a baby, there's a precipitous drop in progesterone. And people who are especially vulnerable to that drop often develop postpartum symptoms. So what brexanolone does is that it replaces the progesterone, hopefully to the 3rd trimester level, to soften that drop. And that's how it works. So a little bit about pharmacology. Pharmacokinetics, it's highly protein-bound, dose-dependent, relative infant dose, which is very important for breastfeeding. The American Association of Psychiatry considers anything less than 10% of maternal weight adjusted dose to be safe. Brexanolone is between 1 to 2%. So yes, patients can breastfeed on it. They do not need to pump and dump. Metabolism, keto reduction, glucuronidation, and sulfuronization. It's independent of cytochrome P450, but it does affect 2C9, to be aware. Excretion, mostly urine and feces. Renal adjustment, not really necessary, but in patients with end-stage renal disease, because it's an IV and because of the, what's it called, a solubizing agent, that's what my pharmacist calls it. It's not advised because that can accumulate. Indications. So basically, this was developed by the insurance companies, and this is how we get insurance companies to pay for it. Any woman who has mild to moderate depressive symptoms as evidenced by any rating scale, PHQ-9, Edinburgh, or the most commonly used. The HAM-Ds were used in the research, but that's a little bit more complicated. The depressive episode needs to start in the 3rd trimester or within 4 weeks postpartum. And patients, insurance will not pay for it, and if this medication costs about $35,000. So if insurance does not pay for it, it's not happening. So they won't pay for it if they're more than 6 months postpartum because the idea is at that time the hormone should have returned to normal. Contraindications of, again, pregnancy, bipolar disorder, current psychosis, and I asterisk that because they're doing research on that now, and active substance use. The reason for that is because in the studies, there were a few episodes of loss of consciousness, and those patients were exclusively taking benzodiazepines. So the side effects, again, 2 severe side effects: hypoxia, sedation, and that's why the REMS is required. Patients need to be on a continuous oxygen monitor. If the patient is sedated, I mean, we expect them to sleep because it's a sedating medication. So we're not really worried if we come in and we call their name or tap them on the shoulder and they wake up. If they are extremely sedated, we have to pause the infusion. If at any point during the infusion they become hypoxic, which our institution defines as oxygen level below 88, we have to stop the infusion and we are not allowed to restart. I have tried. It's an FDA requirement and we are not allowed. And we had 1 treatment interruption because this is someone who had likely undiagnosed sleep apnea and was hypoxic, was already getting better, but we had no choice but to stop the infusion on day 2. Other side effects: lightheadedness, hot flashes, headaches, fatigue. Those are typically transient. So I wanted to show this graph, and I know that we're running out of time, but I did want to show, this is from the original studies, how brexanolone in the orange starts to separate from placebo very early in the treatment. And we can see that it's sustained up until 30 days in the studies. A Christiana Care, a de-identified, shuffled list of our patients, but you can see their PHQ-9s and their post-PHQ-9s here. And as I said, most of the patients came in the moderate to severe range, and by the time they're leaving on Thursday morning, they're in the mild to moderate range. Yes, there is a patient who we appear to make worse, patient 13, but we continue to follow her in our practice, and about 3 weeks after, her depressive symptoms settled, and they remain settled till now. Zuranolone came on market in December of last year, and it's basically an oral version of brexanolone, made by the same company, does the same thing. It's a little bit cheaper, if you can call it that, costs about $16,000. Again, insurance companies are covering it most times. Similar, again, it's the exact same mechanism of action. The onset to symptom remission probably lags by about 24 hours. And what else? So again, this is from the original research. You can see day 2, day 3 starts to separate from placebo. And in this, it's sustained to about 45 days in the studies. So it's dosed. Again, access is much improved. You don't need any specialized training to dose it. 50 milligrams a day. They take that for 14 days and they're done. Usually take it at night because it is somewhat sedating. Don't drive, don't operate heavy machinery. What we do pregnancy tests. We check their liver and their kidneys because if they have hepatic impairment or renal impairment, the dose goes down to 30 milligrams. And we also counsel them to take it with food. These are new moms, so we always have to tell them, while you're on this medication, you cannot be the sole caregiver for your baby at night. Someone else needs to be there to parent, as we would do with any sedating medication. So future directions for research, these medications they're trying to explore, well, what do they do and what other neurotransmitters do they affect? And what is the use in patients with bipolar disorder and postpartum psychosis? So that's all I have today. Thank you so much.
Be staying for lunch? Yes. Okay. Because of time, we'll have to hold questions as well, but Dr. Mokonogho will be staying for lunch, and please feel free to approach her. Thank you so much. Well, that concludes our celebratory SUNY Downstate Psychiatry Conference. I want to thank the other members of the planning committee, Dr. McAfee, Dr. Viss, of course, you've been a wonderful consultant to this committee, Dr. Gallanter, Dr. Mursa, Dr. Ananthamurthy. I hope I haven't forgotten anyone. I want to thank all of you for coming today. This has been really an enjoyable experience, certainly for me, and I hope it has been for you.